Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse. If you're new to this channel, welcome. Glad to have you watching and listening. Please feel free to like, comment, subscribe. Um, I usually start off, or have been starting off, I should say, with a update praise report. Um, just backing up just a little bit. Last episode, I talked about resilience in the face of depression. That the science continues to show that depression is not caused by a chemical imbalance, but by having sad events or issues come up where the person who's dealing with depression focuses on those events and the thoughts surrounding those events and the feelings and just circles and circles until they become addicted to those thoughts. And I was there. And one of the lessons I learned in terms of being resilient is looking for the silver lining in anything, trying to find nuggets of gratitude, things to be grateful for. Things to be grateful for. So, in terms of things to be grateful for, and this is going to be a combination of a twist, is I'm still trying to find nursing work here in Kentucky. My wife and I recently moved to Kentucky. What a beautiful state, but it is shivering out. It was 8 degrees when I woke up this morning and 0 just before that. But I'm still looking for at least part-time nursing work. I was forced into semi-retirement, maybe retirement from a point of view, after being terminated, whether because of age or my stance on the COVID vaccines, or because I advocated too strongly for my lung cancer patient who wanted to be palliative sedated, which is legal in all 50 states. Don't know. I have my feelings. Time may never tell. But in terms of being gratitude, I'm struggling with, am I going to be able to find work? And my wife and I were shopping this weekend. She was making what may be the last trip up to Pennsylvania. And we wanted to get a small gift for one of our neighbors for how helpful she's been in our transition. And I was sharing with her, I don't know if I'll be able to find a job in Kentucky. There's a lot of full-time work for nurses. Can't speak on vaccination status, but there's full-time work for nurses, but no part-time. And I'd rather not be driving several hours a day just to get to that part-time job. So right now, just lamenting that. But God is good, and here the book sales continue. Dr. Andy commenting on LinkedIn about the Mastering Eligibility book, how to know how to do admissions in general for any diagnosis, because hospice is about the prognosis, not the diagnosis. That's been taking off. And wow, this is like a low-end Social Security check. Can't live off of it by itself, and certainly not guaranteed like the Social Security check. Not that it's guaranteed, but at least for now, you get a monthly amount that you can count on until you get a notice that they're cutting it by X%. But with the book sales, could be 0 one day and 20 the next, or 0 and 1, whatever that goes. But my wife made the comment, maybe that's your new career, that you are an author. So God is good. There are ways to move forward. There are ways. So that's my gratitude, is I'm thankful that the books are selling. I'm thankful for my wife, Laura. She actually suggested the next book. I got 2 chapters written, and that is a book to encourage nursing students as well as nurses who are in the hospital or other settings to consider becoming a hospice nurse. So it's going to be an entry level book. 2 chapters in. My desktop computer died, so everything's being worked on my laptop. A little bit slower pace. I'm getting more used to the commands on a MacBook versus the PC desktop, but that's that. But in today's episode, I would like to go over the end of life books that I've written for family members and caregivers. Just a brief outline for these books. I'll have the link to the entire series, plus one book that I had to remove from the series based on how Amazon views planners, which planners can't be part of a series, even if it kind of goes with all the books in the series, but those are the rules. So here are all 11 books, 10 of them in the series, the planner not in the series. One of the things I appreciate as a hospice nurse is when I have family members who are keeping track, or caregivers, of the changes in condition for their loved one. As you progress in hospice, if you're watching this from the nursing side or have an interest in being a hospice nurse, the vital signs get to mean almost nothing. They have some meaning, but not like in any other setting of healthcare. I cannot count the times, I've lost track of the times, that family members have said, but their vitals are normal. What's going on? Well, the vitals don't really paint the picture. So I have family members that are very good at keeping track of changes in condition, and I have other family members that are not good at it. And I'll have family members, can I write something up for them on how to keep track of things? So one of the earlier books that I wrote is the Daily Hospice Care Planner that goes through, and please bear with me, and as I said in earlier videos, these are live, but it's going over keeping track of the demographics in case there's multiple caregivers. There's a place to fill out. This is not in ebook form, it's only paperback, but there's a place to put out the demographics. It talks about 5 wishes, which looks at advanced care planning, and a place to fill out the 5 wishes. And you can, Amazon doesn't make it easy to do pull outs or tear outs, but you can make copies of the pages. Important phone numbers gives examples and then a place to put the phone numbers. If you're having third-party caregivers involved, what is their schedule? Gives an example, then a place to fill out for the caregiver schedule. Also, what tasks are being done by the caregivers? What are they actually doing in their time? Has an area where it goes over the importance of a medication list, gives an example list. The list includes not only the medication name, the strength, which is commonly known as the dose, although technically you can argue the dose is how many together make the dose, but I'll leave it between one group and another rather not argue. How many to take, when to take, whether it's routine or as needed, which is PRN, any precautions, which are important, and what to monitor when you're giving the medication. There's a medication tracking template for the as needed meds. Keeping track of refills is unbelievably important. Most of the time, medications do not keep somebody alive. There's some fine print, but most of the time they don't keep somebody alive. But it is very important to know when you're getting low on most medications. So there's a sheet to keep track of refills. There's diabetic management in terms of keeping track of the diabetic medications, including the readings. There's dietary intake. I cannot tell you how often discussions take place over mom, dad, brother, sister, aunt, uncle, niece, cousin, etc. They're not eating or drinking. And sometimes they're actually intaking more than what you know. So if you add it all up, you have a chance to keep track of it. And we're interested in comfort, so we're not interested in pushing food or fluids, but we're interested in comfort. There's tracking weight. So if you come on board for hospice, sometimes the diagnosis is protein calorie malnutrition. Uh, Sounds bad. Nobody's doing malnutrition on purpose, we hope. We're not talking about voluntary stop eating and drinking, but they come on for abnormal weight loss. And in order to stay on hospice for abnormal weight loss, you need to keep track of the weight as best you can. So that's there. There's continence care, keeping track of continence care, skin inspection and wound care. Again, with taking notes on that. Journaling changes in condition, including giving examples. Notes from the hospice visiting nurse. Sometimes family members have to run out, and maybe there's a friend or a caregiver there. Wouldn't it be nice to know what the hospice nurse did if the hospice nurse could not talk at the time? Or maybe they did have that conversation, but memory, how many times, if you're already in hospice, you had a conversation with the nurse, but because of everything going on, what did they say? Wouldn't you like to have a note for what was going on? Disease process and progression tracking, memorable moments. This comes in very handy if you're looking at obituaries or working through grief and you want to create a collage of not only pictures and events and tie them together. Memorable moments can come in so handy. Supply list and tracking. And for all the books, by the way, I'm not going to go page by page. It's just for this one, I would. This does go over the dying process at end of life, what to expect. Barbara Kynes gives a bird's eye view. This is based off of her Gone From My Sight book. So it's a little bit more in summary. Conclusion, some light resources, and then we're there. And I do try for all of my books for caregivers and family members, I do try to have the lowest price that I can have, where I'm still getting paid for the what I put into the work. But keeping in mind, a lot of times families that have loved ones on hospice have too much going on. I don't want to take advantage of them from any perspective. Now, in terms of quick rundowns, again, I'm not going to do chapter by chapter for the remaining books. But one of the subjects that comes up on a regular basis is what is the difference between palliative care and hospice care? And how do I know what to choose for my loved one? So this book goes over the difference between the two. And in general, palliative care, hospice is palliative care at end of life, but with a lot of restrictions. They have to have a terminal prognosis of 6 months or less. It's the prognosis, not the diagnosis. I cannot stress that enough. Yes, a diagnosis matters, but that's for the hospice company to work through. If they're terminal, that's the key. That's the key. So they have to have a terminal prognosis 6 months or less. You have to continue to prove to Medicare that they're terminal as they go through the process, which is why you have people like Jimmy Carter, who was on for a year or more. Some people can be on longer. If you can prove it wasn't 6 months then, but it's going to be 6 months now, here is the proof. Key. But in addition to the terminal prognosis, you can't have aggressive or curative treatment. And that can be very strict. Parkinson's patient wants to have physical therapy, which has been proven to help the person with Parkinson's disease have higher quality of life. You would think it would be covered under hospice because it's focused on comfort care, quality of life for whatever life remains. And PT does not extend life, but Medicare, no. You could have it for safety reasons. You have like a couple sessions, but not for maintenance. the palliative care you can. Palliative care deals with the comfort side of it, which hospice does. The spiritual side of it, which hospice does, covers every element of hospice, but without the strings attached. There's no strings. I wish we lived in the world of no fine print. Fine print is sometimes insurance handles palliative care differently than hospice, so there might be monetary strings, but in terms of the actual services, if you have a palliative care team and a hospice care team, hopefully they're going to be doing the exact same thing, comfort-wise. But the palliative care team, the restriction should be close to zero. Go get aggressive treatment as you desire. Hospice, the only time that they allow aggressive treatment is if the FDA doesn't recognize the treatment. My most memorable patient that I hope to never forget, Billy. Billy was trying silver Solvadine to cure his cancer. It didn't work. I'm not promoting certain types of therapy in terms of other therapies. I'm not saying it wouldn't work in some cases. I'm taking I don't know. I don't know it all. But not FDA approved could do it to his heart's content on hospice. But if it's FDA recognized, sometimes there's fine print with that too. It's not recognized by the FDA officially, but it's enough of an experiment that the FDA kind of looking at it. So take it with a grain of salt. If it's not FDA approved, you have to check with your hospice provider, and they'll check with their medical director and do, check into it. But this book goes over how do you make that decision? What's the difference between the two? How do you make that decision? Okay, that book takes you through what's the difference between hospice care and palliative care. But the next big question, when is it time for hospice? When is it time for hospice? So this book goes over how do you know you're not a hospice nurse. Most people that would be watching till now, if you're a hospice nurse and interested, I applaud you. Keep watching. I'm not telling you to leave. But if you're watching this and you're a family member or caregiver, somebody saying, I have somebody, they've been chronically ill, they've been in and out of the hospital, in and out of the ER, I just don't know. How do you know? Or you have those family members that don't want to go to the doctor. How would I know? This book walks you through how to make an informed decision to know. Now the bottom line, and maybe I'm making it that you don't buy the book. If you think that person's not going to be around next year, now this is being filmed January 15th, 2025. So if you don't see them around by the end of this year, December 31st or early 2026, call hospice for an evaluation. But if you're just not sure, this book does walk you through different things to do in terms of eligibility, who to call, the hospice roles, walks you through. Okay, you're on hospice now. Or maybe you're questioning, how do you pick the right team? Because hospice, like the word hospital and doctor and nurse practitioner, those are generic words. Somebody goes, you need a doctor. I'm hoping you look up doctors in your area. What are their specialties? What are their reviews? Same thing goes for hospice. It's a federally run program, so hopefully everybody's following the rules. But in my many years of being a hospice nurse, there are agencies that break the rules, that commit fraud. I'm hoping they're on a low end. There are agencies that do the bare bones minimum because they want to make the maximum dollar. And there are agencies that excel through the roof. How are you going to know? And what are your rights? So this book was written in thanks to a lady by the name of Amy. Amy, if you're watching this from California, Amy had a situation. She brought this up on the Hospice and End of Life group on Facebook. There's a lot of wrong things that were being done in her father's case. And I had mentioned in other videos, comment and message me if you need to talk to somebody. I don't know all the answers, but for right now, I've been offering my time for free. This is not trying to make money or sell you something or even sell you the book. But I went back and forth with Amy on Facebook Messenger for the good part of an entire day, no charge, back and forth, where basically this is before this book was written. She's part of the cause for this book. Her and Tanya Frazier. Tanya Frazier RN. Thank you, Tanya. Um, but here, there were so many things going wrong in her father's case, and so I'm looking up rules and regulations here and there on the CMS site and related sites, and basically giving her what ended up being all the majority of the resources and references for this book we discussed. Now, I didn't just here look at this and here gave that. I was presenting it to her in a way that she can nibble on it, like as portions of a meal. So it wasn't, wham, slam you with the book or slam you with the technical information. So this was written for families and caregivers in mind. How do you know what your rights are? How do you know you have a good hospice agency in the first place? And who do you complain to? In what order, in terms of chain of command, to get the most effective results if you have to complain? I can't guarantee your results. But this book goes through your rights and how to deal with the issues. When somebody they're on hospice, they're given hopefully a comfort kit the same day as their loved one is admitted to hospice. And this book goes over the common medications that are used to hopefully reduce fear in the administration of those medications. Now, as a hospice nurse myself, I take education very seriously. If you've been watching any of my videos, hopefully what you're gathering is I take time with my patients and my families. My home visits would average about an hour and a half. Would not, like an hour might be a minimum. It would not be uncommon to run 2 hours because I would take the time not only to interview like what happened between the last visit and now, and how are you feeling, and tell me more about this and tell me more about that, but I'd be going over the medications. Now, this is what you should be looking for between now and the next visit. And there's a possibility this could happen too. And this is what to give if that happens. I want you to call the main number, but I also don't want you to be afraid to give this medication or that. Comfort matters the most. So this book goes over the common medications that are used in hospice just to reduce the fear of giving those medications. Now, I mentioned with the daily planner that one of the most common questions is they're not eating enough or they're not eating. So one of the books I wrote is Nourishing Hope. Nourishing Hope. And out of a lot of these books, I have a level of pride with it. This book does include bonus chapters where I actually gave recipes covering a wide variety of situations. I just want to put that out there in advance of going over the book. But recipes of like, what if they're on a puree diet, or what if you're looking at dealing with more hydration issues because mom's not drinking and you think, or dad, or whoever, they're not getting in enough hydration, or they're not getting enough protein, or what if they have a heart condition, what if they have this condition or that. So I go over, there are pages upon pages in the end giving recipes, easy to do recipes, including recipes that you could put in a meal plan and put in a freezer or the fridge and work through. A lot of research went into that to validate that like this isn't just a thought. This is practical. This is what you could do in terms of nourishing hope. And it does go over, there will come a time where your loved one's not going to eat. It's normal. Our bodies are beautifully and wonderfully made, and our bodies know how to die. And if we push food and we push liquid, it's always okay to encourage. And there's a fine line between nagging and encouragement. And I'm not going to judge as to what that line is. I'm not in your shoes. But if you push food and liquids towards the very end, when it is harmful, you could actually cause harm. They're going to suffer. And when they start actually dying, they could actually take longer. And they're like, why aren't they gone? This is so much. They're suffering. Why aren't they gone yet? And sadly, sometimes it's because too much was given at the wrong time. But until then, because I always promote having somebody come on sooner to hospice than later. In the beginning, especially if they're on and you think they have 3 months, 6 months, even if it's only a month or two, this can be very helpful in terms of knowing what's possible, in terms of promoting something to eat, how to deal with taste changes. It tastes like cardboard. I can't get them to eat anything. They don't like the texture. This goes over helpful supplements, different things to help restore taste, holistic strategies, and so on. I really like looking at the holistic side of things. Family members, caregivers. I was just dealing with this with one of the persons I'm trying to help remotely as best I can deal with this. Their loved ones dying. What can I do? The family members asking this, and I'm also, what can I do? I do pray, and I do have those thoughts and prayers, but at the end of the day, it's like, did we do anything that we could? And so one of the books that I wrote, because a lot of times family members will tell me they have trouble connecting with their terminally ill loved one. So this book is about how to form those connections. And it's using evidence-based practices. One of my heroes has since passed away, Naomi Fell. I wish I would have known her. She's a social worker who came up with a set of techniques that any one of you can do. It's called validation therapy. And it really helps on forming bonds and connection and getting through challenging situations. I've used it in conflict management. I've used it in delivering bad news. And I've used it with combative patients and just having somebody that you don't think you can get a connection with. And even in order to build trust, this is so valuable. If you're a nurse watching this, this can help you connect with your patients if you're having trouble. Those bear of patients that you can't, like nobody seems to be able to connect with. These are techniques I've employed that have helped me to connect with my patients. And so this goes over a lot of different methods and techniques for working no matter their diagnosis. So whether they have dementia, they have cognitive issues, or they have cancer, or anything going on, this can help. We're coming towards the end. So there are times when somebody's terminally ill and they can't take it anymore. And medically, you have done everything you possibly could to provide comfort. And from a purely technical standpoint, they should be, but they're not, and that matters. I've had arguments with doctors who said, but they should be pain-free by now. Excuse me, doctor. They're saying they're not. And I'm going to advocate for them because they matter. Your loved one matters. And if they're uncomfortable and they want it to get over and done with, and this is a very controversial area in certain segments, so I'm not talking about medical aid in dying. I'm not a fan of certain phrases because all my patients who died naturally died with dignity. But One of the areas talking about dying with dignity that people, like my patient, what can I do to take control of this and give them control, is dying in dignity. This is not medical aid in dying. This is voluntarily stopping to eat and to drink. So there does come a point in time in the natural dying process where they'll stop eating and drinking. This goes over what if I want to do that before it happens naturally? So this goes over the process and the emotional challenges and what the guides to deal with, how to talk to the healthcare staff. What if you're at a facility? This walks you through the basics of working through that. Now, what usually goes hand in hand for VSET, and I actually shared this with a family patient this morning. It was a very young person asking. They admitted they're overweight. They know because they're very young it can take long, and they're just asking, how long does this take? And this book does give guidelines, and I do apologize. It's been a while since I've written a book. I do believe that it's anywhere from 14 to 21 days if you've completely stopped eating and drinking as a ballpark. But if you're young and you're overweight, that could be very hard to do. And I can't speak for everybody, and I don't know how much of what I'm going to say is going to meld, like you're putting your own thoughts and feelings into somebody else's situation, and you're not in their shoes. So I apologize if I'm crossing boundaries in that area. But there was a time where I was severely overweight. I was 200 over 250 pounds at one time in my life, and I knew in the very beginning of my weight loss journey, it was hard to give up food. So you have somebody that's overweight and they know that and they want to speed up the process. That could be emotionally and physically challenging, and you deal with, I want to get this over and done with. Then there's last measures that this is legal, this is ethical, legal, and from my perspective as a follower of Christ Jesus, moral in all 50 states of the United States of America, palliative sedation is legal. And that is where you give enough of the sedative medications. Now, the specific medications will vary by location, state, pharmacy, what's available. I've used morphine, haloperidol, and lorazepam in Pennsylvania. I've not dealt with this in Kentucky. We just moved to Kentucky. But yeah, I think it was 2 or 3 weeks ago when I apologize. I remember our phone call, Tanya. She called me about a patient suffering from glioblastoma, and we were talking about palliative sedation. And so the medication mix where she's at, which was a nearby state to Kentucky, similar subject matter in terms of the morphine, haloperidol, lorazepam, but it can vary. So this book does go over the varied medications that are used, some dosage guidelines, but this is one where the hospice nurse needs to, in my opinion, needs to be the one to initiate until the patient is completely sedated. You're not trying to kill them. This is what makes it different from euthanizing. You're trying to get them into a sleep from which they will never wake up. So unlike intubating where you're testing could they be extubated, you are purposely sedating them to where they will never wake up. Now they won't be eating and drinking, and family members should not be, because you don't put food or water down a sleeping person's throat if you care about them. So yes, they will die faster, but this guarantees as best you can. As best you can. That's the fine print. They should not wake up. Now, typically, the hospice nurse initiates, and then the caregivers follow through, calling hospice if it appears that they might be coming out of it. And depending on the diagnoses that are involved, will determine how frequently the medications are given. Fine print, that's a good fine print in my experience and opinion. you have a routine schedule to keep them sedated, and you have PRN meds that can be given at the exact same time or shortly thereafter to ensure they remain sedated. This is very doable, legal all 50 states. This goes over the foundational principles. Last item, we're almost done. Thank you for watching for this long. Caregiver's lifetime. I've lost family members and loved ones. And if you're watching this, you may have, or you're dealing with it now, or you're worried that you might. This is a book talking about self-care. If you empty your cup, you can't take care. I've had so many conversations with, a lot of times it's the adult children that are literally burning themselves out. And I'm trying to find them every resource I can as a hospice nurse, including respite and everything else, involving the team, the social worker, and so on. Needs a village. If they have an issue, they're not going to be there. I still remember the daughter of the pulmonary fibrosis patient, where this was to me, God's involved in everything. They're admitting the patient. I may have shared this in one of my previous videos. The daughter goes out to talk to her neighbor. I hear a crash as I'm doing the admission, and I go out, and here I find the daughter on the cement. I want to say sidewalk, but the step up from the sidewalk, and I could quickly tell observationally she's going into shock, and it took some convincing to get her to allow me to call an ambulance and get her to the hospital. It turned out she did fracture her hip. She would have died if she would have stayed there. But you have to take care of yourself. And if you don't, you're not going to be there for your loved one, or they're not going to receive the best care you could give if you're burnt out. So this book goes over different methods, evidence-based, different ideas for you to take care of yourself and make it through to the end. So that's what I have. I'll put a link in the description for the series, as well as the planner that Amazon doesn't allow in the series. If you have any questions, please feel free to comment. If you like this type of material, subscribe. In a future videos, I do want to give updates of how things are working from the semi-retirement, retirement perspective financially. But thank you for watching. God bless, and bye.